a large session for question and answer, but we also have some features that Liz is going to share with us here in a minute that you can utilize here in the Zoom to make sure you get those questions documented so that we can definitely reach out and make sure we provide you a comprehensive answer if we can't answer them live here in the session. So I'm going to move our slides forward here. Today we have a few facilitators and great speakers. So myself, Bonnie Barron, she, her pronouns, and I am the HCBS 1915I Enhancement Analyst. I am going to toss it to our other speakers. So Ashley Purdy, if you want to introduce yourself.
Yeah, thanks, Bonnie. Hi, y'all. My name's Ashley Purdy, she, her pronouns, and I'm the Children's Behavioral Health Clinical Review Coordinator on the HCBS team. So I'll pass it over to Greg.
Good morning, everyone. I am Greg Tippett, the Senior Care Coordination Contract Strategist, and one of the responsibilities in that role is acting as the contract administrator for the IQA Comagine Health contract. And I will pass it now to Natasha.
Thanks, Greg. Hi, everyone. Natasha Martin, she, her pronouns. I'm the HCBS 1915I Operations and Policy Analyst. And I guess we're ready to move slides.
Awesome. Thank you. We also have some other subject matter experts in the room that are going to be monitoring our chats, going to be working to answer questions that come in. So we just want to call out who you want to know as your HCBS team and also our Comagine support team. So Cassie LeVue, myself, Natasha, Michael Oyster is here from our mental health unit, Liz Cancel, Ashley Purdy, Greg, Aaron Bryant, Nikki Alkery, I never say her name right, I apologize, and Kim Roberts. So we appreciate everybody being here. We're super excited to be able to share information and answer some questions. So I will pass it over to Liz. She's going to review some of the chat features and Zoom features that you can utilize in today's meeting. Liz?
Hello, everyone. Liz Cancel, Home and Community-Based Services Senior Policy Analyst. Welcome to our webinar. Please share your feedback, reaction, and responses via chat or our Q&A. So our audio button, it's on your bottom left. With that button, you can mute and unmute yourself. Then if you want to do the video, you have the button just beside that on the right. Your reaction and chat button are in the middle of your screen in the bottom. And then if you want more, if you click more, those are the three dots on the right. You can have the captions and also the Q&A feature. Next. Be sure that you keep your mic on mute during the presentation. If you have any question, as I mentioned, you can input the questions on the chat or wait until the Q&A session to ask your question. Thank you so much. Pass to Bonnie.
Great. Thank you, Liz. Yes, the Q&A feature is great, especially for those really detailed questions maybe pertaining to a specific beneficiary or a specific process around one of your individuals. We do want to ask that we protect PHI, so protected health information. We want to refrain from using here because it is a recorded session. It is going to be made public. We would like to ensure that PHI is protected. And just we will remind as we go through if we need to. So today on the agenda, we're going to be talking a little bit about the state plan option for HCBS and the authority around that. We're going to be talking about the roles and responsibilities for OHA and the roles and responsibilities for Comagine Health. Then we're going to take a small break and get up and stretch. And then we will go through specifically Comagine Health processes to hopefully answer some questions that have been provided in the registration. So we did get all of those registration questions and have been working through to try and answer those in some of the slides that you'll see. And then we'll have a pretty large session for the open discussion and Q&A, because we do want to be able to answer as many questions live as we can. And then if something needs maybe an offline conversation or a little bit more detailed conversation, we will gather your contact information and we can reach out and provide technical assistance in that way. And then we'll talk about a little bit about future events and close out. So I am going to move us to the next slide. And our next speaker is going to be Natasha.
Hey, Bonnie, it's Matthew. I just sent you a private message for your FYI.
Okay, thank you, Matthew. Thank you.
Thanks, Bonnie. So my part of this is we're going to talk about the state plan option for 1915I and what OHA's responsibilities are. So let's go get the next slide here. So 1915I is provided through what's known as a state plan option. Just one of those things that any given state can set up with CMS, and we've chosen to do so. So we provide HCBS 1915I as part of our state plan that was approved on January 1st, 2022. So we've been doing this a little while. The option has got a 5-year approval period. So we're most of the way through our 5-year approval period, and we'll be setting up a new 5-year period in the beginning of 2027. We do very much intend to renew this option and continue to provide HCBS and continue to expand access to eligible individuals. The chart here is from our actual state plan agreement with CMS. And what this chart does is it goes through and says, of the parts of setting up a person on HCBS under the 1915I state plan option, who's responsible for what? So in the first column, we have the different functions like individual state plan enrollment and eligibility and execution of the provider agreement, all these kinds of things. And we have our 4 columns here for who's responsible for what. Medicaid agency is OHA. That's us. We've got a hand in all of the things. Other state operating agencies are things like ODHS offices and the AAA offices. They participate in 1915I in that they do like an OHP eligibility evaluation. Our third column here, contracted entity, that's our IQA, which is Comagine Health. You see they only have a couple of check boxes under review the service plans, prior authorization, utilization management, and quality assurance. This separation of powers is very important, and it's part of what makes the Comagine the independent and qualified agent. The independent part's really important there. So this is a basic overview of who's responsible for what, and we got a lot more details in the next slide because I know that this chart takes a little bit of looking at to really get it into your brain. So let's go to the next slide here. And the next, yeah, perfect. There you go. So Oregon Health Authority's responsibilities as it relates to 1915I. We have a lot of check boxes marked, so there's quite a few slides here. OHA is responsible for operating the home and community-based services mental health benefit. We direct and delegate and manage the contracts to administer the HCBS program, so we are the contract admin for Comagine. We ensure that conflict of interest standards for service activities are created and adhered to for everyone's protection. Nobody likes conflicts of interest. It's our responsibility to assure fair hearings and appeals for HCBS individuals. That's very much an OHA thing, not a Comagine thing. We set all the provider rates, which is highlighted because it's important. And the dates for the HCBS services in the secure residential treatment facilities. So we do all the residential rates, all the AFH rates, all the SRTF rates. We are responsible for all of that. Mm-hmm. We are also responsible for ensuring that we don't claim federal match. It's called federal financial participation. We don't claim federal match for room and board because we're not supposed to do that. So we need to we're responsible for setting up processes to make sure that doesn't happen. We are also responsible for reporting to CMS on the activities and oversight of Comagine and any other contractors that are in this space to ensure compliance and accountability. Comagine must be independent, but that has a very specific meaning, so we definitely have plenty of oversight there in making sure that all the activities match what we agreed with the federal government and do what we mean for them to do. Let's go to the next slide. Continued. I think we have 3 of these slides. So this is fun. Continued. We are responsible for conducting the medical necessity and appropriateness reviews for SRTF stays based on the IQA's recommendation. So when you go and get a person evaluated for this, and it seems like you get a response like, no, it doesn't meet medical necessity. It's OHA that made that decision, not Comagine. So that's easy to get your brain crossed on that one. We are also responsible for reviewing and approving all of the denials or closures prior to action. So that's another one of those OHA done it, not Comagine done it. We are responsible for ensuring that the services are provided in an approved HCBS setting. That's got lots and lots of meanings that we will gloss over at this time. It's our responsibility to ensure that we're not duplicating services with other state plan or other waivered services. So you aren't allowed to get an in-home care person from APD and OHA at the same time. We have to make sure that doesn't happen, and that's OHA's responsibility. We are responsible for providing technical and training assistance to all of its contractors and to all of you, our providers and CMHPs. We're also responsible to provide training and facilitate community engagement with all of you, our providers, our CMHPs, our community partners. Let's go to the next slide. So we have, and I'm sure that you guys have all been here for the ride. So we, OHA, have begun providing trainings and engagement opportunities on all the topics identified by providers, by you, that affect providers and community partners and the IQA, including but not limited to, and we have done webinars on the vast majority of this, probably all of this, but not by these names, including but not limited to rights and expectations, what is an HCBS setting, what is required of a setting to be HCBS, how do individually based limitations or IBLs work, residency agreements, which you can and can't have in there, individual services and benefits, how do referrals work, care coordination and how that works, how one conducts an involuntary move out and for what reasons you're allowed to do that, all the hearings and appeal processes, our related program PC20 and agency with choice overviews, and IQA provider process overviews. And all of these things are hosted at that link there at the bottom on our training and engagement page, where we earlier said that this recording would be up in a couple of weeks. Thanks. Cassie's flagged in the chat here that some of these are upcoming webinar topics based upon all of those wonderful registration questions that you guys ask and answer. Let's go to the next slide. And I think it might not be my slide anymore.
Yes,
I'll
we
pass
will
it
be
to Greg.
passing over to Greg. Yeah, thank you, Natasha.
Of course.
Greg.
Hello, I am going to speak on the roles and responsibilities for Comagine Health. And so giving a little bit more detail to the information Natasha just shared. So we can go to the next slide, please. So as mentioned, Comagine Health is our independent and qualified agent, and they have been acting that role since 2020. And specifically, the IQA role is for Oregon's HCBS 1959 program. And they ensure services and supports are delivered according to individual need. And those needs have to be documented in the Person Service Center Plan, which is also a responsibility of theirs to create. So they do receive referrals for assessments, from any source and perform service eligibility checks for potential eligible 1959 members. Reviews, so Comagine reviews individuals for service eligibility, including age, OHP status, and confirming a eligible chronic mental illness or severe and persistent mental illness diagnosis that has been documented in medical records submitted. And then the next step in their responsibilities is performing the functional needs assessment, the initial one and ongoing, to make sure that there's a whole person centered approach when connecting individuals with the needed services and supports. And then they are also responsible for reviewing and approving the individual-based limitations with the providers, individuals, and their representatives. So, next slide, please. So other functions of the IQA are to ensure individuals are offered options among available settings, services, and providers. So the focus really is on giving choice to the individuals needing services. And within that process is really that creation of the person-centered service planning. And that is with any one individual would like at that, involved in that process. So providers, family members, friends, any type of support that they would like there to offer insight or support them individually, they are included. And then the IQA is also responsible for making recommendations to OHA for secure residential treatment facility admissions. And those decisions, as Natasha previously mentioned, are OHA's responsibility. However, we do rely on Comagine Health to provide a recommendation for those. So the next item here is, circling back to that person-centered service plan, the PCSP, is really collaborating with individuals on the care team to ensure a continuity of care. And that can be with multiple providers offering services, or it can also mean connecting with other care coordinators with other entities. And that's really what that next bullet point speaks to, with managing transitions and warm handoffs between settings as well. And then last year on this list, the IQA is responsible for submitting the prior authorization request for the medical appropriateness and medical necessity reviews for SRTF placements. And we can go ahead and go to the next slide.
Greg, I just wanted to call out there are going to be some of the bullet points throughout the slide deck that speaks to non-HCBS 1915I supports and processes that Comagine does do, because they do more than just HCBS 1915I. So SRTFs, those secure residential treatment facility placements, are not a 1915I approved HCBS setting. So I just wanted to call that out, that some of these responsibilities do highlight what Comagine does, but may not apply to HCBS.
Yes, thank you, Bonnie. There are a number of functions that Comagine Health performs for OHA that are beyond the scope of their IQA role with the HCBS 1959 program. All right, and then when we dive down a little bit deeper, looking at the qualifications of IQA assessors. So these are the individuals that are completing the needs-based evaluations. and the individuals are required to meet the Qualified Mental Health Professional (QMHP) um, requirements. So those qualifications are a graduate degree in psychology, or a bachelor's in nursing and a license in the state of Oregon. So that does need to be a current license. Uh, or it can be a graduate degree in social work or a graduate degree in behavioral science. Um, and there's also the opportunity for a graduate degree in recreational art or music therapy. And lastly, there's the option of having a bachelor's degree in occupational therapy with a current license in the state of Oregon. And all of those, if the degree and licensure requirements are met, uh, they do also have to have the education and experience to perform these assessments. So they have to show that they are competent in administering this type of needs-based assessment as well. And I believe with that one, I'll pass it back to Bonnie here.
Great. Well, we're slightly ahead of schedule, so that's good. We never quite know how to allot time when we're speaking. So we are going to take just a few minutes of a break, and we'll probably come back at 10:02. So go ahead and maybe stand up and stretch a little bit, and we will be right back with you at 10:02. During this time, if you've not wanting to stand up yet, you can also put questions in the chat and the Q&A feature as well. Okay. Well, hopefully everybody got a chance to stand up and move around and get a drink or refill your coffee. We will get started here again, and I'm going to move us forward. We're going to be talking a little bit more about those Comagine processes. So diving more specifically into some of the actual processes that Comagine uses to operate as the independent qualified agent. So the first speaker, I'm going to have Ashley touch base a little bit on the methodology that Comagine Health uses.
Thanks, Bonnie. So I know the header of this slide says Comagine Health Methodology, but this is just going to be really short, like crash course on the golden thread, which I'm sure a lot of y'all have heard of. But it is all I can think of, like, it's the gold standard, right, for kind of healthcare process and documentation. So how it starts is it begins with that assessment. So as Greg was mentioning, the qualifications of the QMHPs at Comagine that are doing the assessments, they also have experience in gathering like historical information, assessing needs, assessing some of those cultural, social, relational aspects of individuals, um, and kind of working on safety plan, diagnosis, those sort of things. So that's the experience the assessors are bringing. And when they are doing the documentation review and talking to providers and talking to individuals, really beginning this golden thread with the assessment that is identifying what are the main clinical problems, what are the diagnoses, what are the like support needs that are currently existing for this person where they are. Um, that continues into the development of treatment planning and the person-centered service plan. So the treatment plan should directly align with that assessment, right? So if an individual is assessed and kind of the team determines, hey, this person really needs support with social activities or relationships with others, the service plan then should directly have something on it that relates to that, right? Like a goal of how are we going to support this person with relationships? How are we going to support them with identifying social activities? What are the needs? What does that look like? So it should be directly tied to that assessment piece, um, as well as kind of capturing the risk and the different goals and the availability of interventions that y'all have. With that, right? So we have the assessment that kind of says what the needs are. The service plan says, here's how we're going to support this individual. The next, like, I would say one of the most crucial pieces that comes next are the progress notes that providers do, because these are identifying the specific services and frequency of how that treatment plan is being acted out. In my previous role working in a residential, we used to, this is kind of the hands and feet of the treatment plan, right? Like without some of these interventions and progress notes, it's just a document. We really need providers and folks working with the individuals to say how it's being acted out. So details about how they're rendered and how the consumer like responded to it and participated, even if they aren't, right? Like, so it should really capture what did that intervention look like? What was the response? What did the provider do in response to that? What does it look like? There is a saying that has been just pounded into my head over the last decade of, if it's not written down, it didn't happen, right? So really all of the interventions and all of the support should be captured some way to really illustrate the work that is being done to support the individual. So we have the assessment, the treatment plan, the progress notes, and all of that leads into, right, the ability to receive reimbursement, because this is kind of how we are showing that the services are being provided that have been identified to this individual needs. So also making sure that it's medically necessary and appropriate, and part of the treatment plan and all the pieces. And it goes both ways, right? Because part of it is to make sure the individual is receiving services that are matching what they need. Also, too, to like make sure that providers aren't being asked to provide services that aren't medically necessary. Like it would make no sense for providers to be asked to provide a service that the individual did not need. So it's really a way to mutually identify how is everyone working collaboratively towards the same goals for this individual and providing a service. Next slide, please. This is kind of
Ashley,
those, oh, go for it.
I apologize. There is a glitch in this slide, and for some reason, it is not showing the entire slide.
Try
I
hitting it
don't know.
again. It might be like an animation.
Oh,
There
see,
we
there
go.
you go. Thank you.
Because
I'll
it
just
glitched on me
edit
when I
that
was
out.
clicking through it too. Thank you.
That scared me. I was like, it's not there.
I was like, I have to memorize it. No, so this is just kind of a graphic showing those four quadrants with arrows. They're really tiny on my screen, so I'm going to do my best kind of to walk it through again, right? But we have the different roles, and how they act within that golden thread. So Comagine is responsible for developing that treatment plan, um, doing some of that, doing like the functional needs assessment, right? And kind of blending it together. That is directly impacted by the mental health assessment and mental health treatment plan, that is made by the mental health provider. So those two documents should really be in support of each other. And then it gets a little bit messier. But right, so we have those two documents and then also influence the assessment from an AFH program as well as the residential care plan that y'all are responsible for, which then influences the daily documentation. So these arrows are really just to indicate that all of these different documents work in tandem together and should, if you were to read them all together, right, they should have similar needs and they should illustrate kind of the same picture, just with a different lens based on who is writing it and who the provider is doing the services. And then just a reminder for what some of the LSI categories are that we might be developing goals in. You have the ADLs category, which is hygiene, meds, feeding, um, support with ambulating, toileting, IDLs, yep, finances, meals, cleaning, transportation, appointments, legal, social, recreational needs, psychosocial skills. So those are managing the symptoms and risks of those impulses, disorganization, regulating emotions, being able to communicate, um, regulating self, navigating relationships with others, and kind of keeping in line impulses. And then the last section is, is the person-centered services and support. So this is modifying the environment and having like routine staffing, the line of sight supervision, the one-on-one support and supervision and monitoring. So those are ways of how do we modify the environment to support those needs. Um, I think that's it for mine. And then pass it back to Greg, and then I'll come back in a little bit to talk about person-centered service plans.
Yeah, now I will invite Greg to start the next section.
Yes. Thank you, Ashley and Bonnie. So as I mentioned previously, there are a number of services that Comagine Health provides that go beyond the 1915I home and community-based services. And previously, some of you may have been knowledgeable about um, the children's services that Comagine Health was providing within a different contract outside of the IQA contract. And with the most recent iteration, all children's and adult behavioral services have been combined into one one IQA contract. So that really doesn't change much in terms of what they are doing, other than some expansion of some services. And so with this slide, I want to point out that the orange settings here are inclusive of the 1959 HCBS services and settings, and blue are additional services and settings that Comagine Health supports. So for the HCBS, those are the 1959 settings, and then BH licensed residential services. And also, state plan personal care is for all ages that qualify. However, that is actually not a uh, one of the IQA function. It is still services that they provide. But those individuals, so it's an HCBS setting, service, but there's some differences in the qualifications of those receiving services. So there's a little nuance there as well. But as far as other IQA, non-IQA services and settings, the SRTFs, which are for 18 and above, PRTS, which is 8 to 18, and there's some qualifiers there as far as 17 and a half, 18, some things like that. But generally speaking, 8 to 18. We have SAPE, the Secure Adolescent Inpatient Program, and SCIP, Secure Child Inpatient Program. And you can see those age differences there. And then the behavioral health behavioral rehabilitative services, which are currently being expanded and really looking forward to getting that service provided. And the young adults in transition, which is sometimes referred to as YAT, and then WISHN, which is young adults with special health care needs, and behavioral health crisis respite, and the Oregon State Hospital. And I do want to note on there as well, Oregon State Hospital is independent of OHA. However, Comagine Health does assessments, especially for that transition planning when an individual is being released from OSH. I think we can go to the next slide. All right. So as I mentioned before, Comagine Health does receive referrals from anywhere for requesting services. And the first item to do so is the CH006 form that can be found on the Comagine Health website. And on that form, it has all the needed information in terms of check boxes. So these other things are going to be listed on there as well. So one is the mental health assessment, and the closer to the referral date, the better, so that it's a clear and accurate depiction of the needs of the individual and their current diagnosis. But the requirement is that it at least has to be within the last year. So current within a year's time of the referral. And then the treatment plan or residential service plan, the requirement there is also within the last year. And progress notes and documentation supporting the need for the requested services. And then additionally, if a cross placement is requested, so if an individual needing behavioral health services and wanting or needing to reside in an APD or DD residential setting, the IQA will need to obtain the residential license, a copy of that to assign the match rate. So moving on from once the provider sends in that completed referral packet, Comagine Health receives that information and will contact the beneficiary and their authorized or legal representatives to schedule an assessment. And I may back up there just one little note. There is a pre-eligibility check that happens internally as well, so that OHA is on the same page as far as making sure that this individual does have those items I mentioned previously with the qualifying SPMI or CMI diagnosis. They have the appropriate OHP coverage and their age as well qualifying for these services. And so once that has been completed, which is pretty quick check there, then the needs-based assessment gets going. And so they reach out to the beneficiary, get that scheduled, and then always give the individual their preference in terms of whether that's an in-person or virtual assessment. And that is noted in their file. And then the 1959 assessment must occur um, at the times and locations that that beneficiary requests. So it really is centered on what the individual wants and what they're most comfortable with. And then,
Greg, this
yes,
last bullet unfortunately was not removed. So this last bullet is actually not applicable at this time. So I will correct that before we post this slide deck. I apologize for that.
thank you. Um, so with that, I think we can go to the next slide, speaking about the purpose and goals. And so the assessment tool that is currently utilized is the level of service inventory, and then also so LSI for short, and then the level of care utilization system, the locus, to determine the level of need and support, and then the corresponding service payment for the tiered rate to the provider, the rendering provider that are actually providing those services. So the needs-based assessment is conducted face-to-face, as I mentioned, either in person or virtually. And as I mentioned as well with the PCSP, if the individual wants other providers involved in that assessment or family members there to support them, that is most welcome. And the assessment itself is really used to determine the actual needs at that moment, or most likely predicted needs for assistance. Um, and those are specifically addressing the IADLs and ADLs that Ashley mentioned. And then lastly, the assessment really zeroes in on how the individual has functioned during the 30 days prior to the assessment, and considers how likely they are to perform in a similar fashion for the next 30 days. And so part of that is that similar timeline there is that the IQA is actually responsible for completing that needs-based assessment within 30 days of receiving that referral packet. So with that, we can move on to the next slide. All right, thank you. The assessment is really designed to inform the development of the person-centered service plan, PCSP, as I mentioned before, and it will outline the services that will be provided, also activities and goals necessary to support the individual and their identified needs. So this isn't just you know, clinical services that are offered. If an individual has a goal of learning to play the guitar or being more social, going to a grocery store or something, those things can be listed as a goal that the team is working towards with that individual. And so the PCSP is designed to, document that progress towards the goal and the stability and independence of that individual to achieve those goals. Additionally, assessments include the perspective of the individual and their identified treatment team. So once again, it's really about the individual themselves and their preferences. And as a group, as a team, the goals are identified, and the delivery of those services for the individual are laid out within the plan with the PCSP. Uh, in general, the assessment length can vary depending on the number of participants, the level of involvement by the beneficiary themselves, or and additionally the authorized representative with regards to participation in the overall process there as well. And then verbal report of support needs and services rendered cannot be captured in the functional needs assessment. So I really want to draw attention to that um, that can be recognized that there's that verbal report, but if we do not have supporting documentation that can back up that report, it will not be able to be considered. So just want to really highlight that area, that documentation of the support need is really required in order to accurately assess the individual. Next slide, please. Thank you. All right. So when it comes to documentation and supporting providers' work, just want to call out how vital of a component that the documentation is for the development and the implementation of the successful treatment plan and also transitioning plan to other levels of care. So with this slide, we'll go over a few items of what detailed documentation can assist with. And those are identifying patterns that can be called out to be addressed in the person-centered service plan so that we can, as a care team, can actually better address the needs and work toward those improved healthcare outcomes and lead to better care. And then additionally, informing mental health providers of necessary patterns that need to be addressed with the appropriate course of treatment. So those certainly are things more on the clinical side with supporting daily interventions and aligning supports for the individual's mental health and their treatment plans. Additionally, documentation is very much needed to support measuring progress towards the self-identified goals in the PCSP and what the ongoing barriers are to really inform updates of future habilitative goals and the supports needed there. So just really want to harp on that so that is really so important for the individual that is choosing that goal, that we are able to support them improving their health care, their health outcome. So a couple other things here: developing a comprehensive history regarding strategies and interventions, so we know what has and hasn't worked in the past, is very much warranted here. We really look for being able to celebrate those successes and helping that individual transition to independent, whether that be independent living on their own or just greater independence within a care setting. And then lastly, documentation is obviously really needed to capture an accurate picture of the type, scope, frequency, and duration of the supports and services provided to an individual. As mentioned before, it needs to be documented or we can't utilize that within the assessment. And that's the same for reassessments and updates to the person-centered service plan. We really need the supporting documentation that shows where we are and where we can go. So with that, I believe I have one more slide here. And so this is speaking on documentation again for provider requirements. And we have some of the OARs listed down at the bottom of the page. But I will briefly go over this in terms of requirement. So OHP providers shall maintain records that fully support the extent of services for which payment has been requested and provide the records as requested. So all the records shall document the service provided, the number of services comprising the service. So the number of services within the overall service that is provided, the extent of the service, the dates that service was provided, and the individual who provided the services. So instead of just writing blanket statements, it really needs to be specific in terms of who provided the services, how long it took, exactly what was done, so that we have a clear report of how that individual was supported. Additionally, clinical records shall document the individual's diagnosis and the medical need for services. So once again, really just supporting what we're already approved for. So if there's really not a need for this individual to receive a certain service, then we can move forward with not assessing for that individual service, and that's kind of how we have to go, is whether it's documented or not. If it's not documented, then we don't have record of it actually being needed. And next, the record shall be noted each time a service is provided and be signed and initialed by the individual providing the service. And lastly, information contained in the record shall be appropriate in quality and quantity to meet the professional standards applicable to the provider. So we have some best practices information that are supplied on the HCBS website. And then we are also available as a team if there are questions regarding the type of information or how detailed the documentation needs to be. You can certainly reach out to the HCBS team here, and Comagine Health is also an option is there in terms of helping providers really document what is needed. So in an assessment, but then also those treatment records as well. And then I believe that is it for me. So we're going to hand that back to Ashley.
Thanks, Greg. Okay, so Greg just did a great job kind of outlining the assessment process in the initial one. So I just wanted to spend a little bit of time talking about reassessments because I know that is something that comes up. So there are three main things that could trigger a reassessment. At minimum, it's every 12 months for an eligibility redetermination. So no matter what, right? Like once a year, that is going to be reassessed. It could also happen if there is a significant change in either the support needs or circumstances of an individual, or if it's requested by the beneficiary or their authorized representative. So those are kind of the three main categories that start the reassessment process. And for the routine ones and for continuity of care, just a heads up for y'all, an IQA team member will reach out no earlier than 60 days, but no later than 30 days prior to when their eligibility expires. So if it expires August 1st, right, like they're not going to reach out any sooner than June 1st, but also no later than July 1st. That's the next month. So sometime in the month of June, in theory, would be when they would be reaching out to schedule that and get that started. Next slide, please, Bonnie. More often, I think it's probably the change of condition that we are looking at. So this is when there is a change in the functioning, which lasts more than 30 days. And or if there's documentation that reflects changes that weren't originally reflected in that initial assessment. So if a piece was missed, maybe documentation got caught up later, maybe we're seeing something change in that baseline. The provider has to resubmit that CH006 form with the change in condition box selected under the request information section. And I believe Liz had linked the CH006 in the chat. If not, we can throw that in there. If the reassessment results in an increase in score that changes the rate, so it goes up to another tier, then the IQA team member will schedule another face-to-face meeting with the beneficiary to make sure that that person service centered plan, make sure the goals are aligned and make sure they're accurate, make sure they're realistic for what, excuse me, the individual is wanting, and also make sure that the support needs that are listed are matching this change in condition. So after that, a new plan of care will be entered for the effective date of complete submission, and that includes the completed CH006, documentation of the change in condition or increased services, documentation of the date of change, the mental health assessment, and the treatment plan and progress note supporting the change of condition. So this is where kind of like we had mentioned before, right? Documenting is very important because that's how we can show that like the change in condition is reflected in the day-to-day and what type of supports are being needed. Next slide, please. So also with this reconsideration request, a provider may request a reconsideration if they believe the original assessment, so either the LSI, the locus, the person-centered service plan, did not capture the individual needs accurately, or if documentation was omitted during that original assessment and was not included. So it must be submitted within 10 business days from the provider's receipt of that assessment packet. So you have 10 days from receiving the packet with the score, assessment, PCSP to request this reconsideration. There is a 1915I reconsideration form that is not mandatory, but highly recommended because that has a checklist of the documentation needed. It gives the space to really clearly outline why is this reconsideration being asked, what are we seeing, and it just gives a really good format on how to lay it all out. So while it's not mandatory, I think it's good practice just to be able to like use it or at least reference it. And then another avenue that is available for reconsideration requests is the rate review committee, or the RRC as it's sometimes referred to. There is an intensive services request form that can be filled out and submitted with supporting documentation. And this is an option when the change in circumstance is not captured by the LSI, such as if there's extensive medical complexities and forensic risks. So if there's a need that is exceeding what can be realistically captured on the LSI, that would be the route to go. Next slide, please. We're going to I want to make sure that we have plenty of time for question and answer. And we've talked a lot kind of about the person service centered plan. So I'm not going to go into detail on everything in this slide, but I think the most important piece to recognize is that it should be written in plain language and in language that matches the beneficiary's needs, right? Like they should be able to read the plan, know what their goals are, feel like it reflects their needs, and that it like is accurate and culturally appropriate, linguistically appropriate, and accessible is the biggest piece of the slide, I would say, is we want to make sure they have access to their care needs and understand them and feel like their voice is really reflected in that process. Go ahead and go to the next slide, Bonnie. So just some process stuff with it. It has to be provided to the individual, provider, and treatment team via email and or snail mail. It has to be reviewed and signed by the individual and or the representative, as well as all folks on the treatment team. And then once that is signed and kind of finalized, the IQA enters the plan of care into MMIS, and then that entry prompts the approval letter for HCBS 1915I services to start, including sending out hearing rights to the individual. Next, and then back to Bonnie.
All right, thank you. Thank you all to my presenters. We really had a lot of questions come in around nursing delegations and the availability of them for our behavioral health or mental health adult foster homes. And so we just wanted to highlight this here and provide a link to the CH011, the nurse delegation form. And so many individuals have tasks that would require staff of the adult foster home to be delegated by a nurse. And that licensed nurse delegates to the staff members, could also be to monitor certain situations in the home or complex medication regimens and things like that. And so this nursing delegation form, again, is not mandatory, but highly recommended because it does provide a layout of the required documentation and information that's going to be needed to support the approval of the request and scoring in the LSI. So delegated nursing tasks can be scored within the LSI to appropriately assign the right tier level in order to capture payment needed for the delegated nurse. If the provider doesn't wish to submit the nursing delegation form, they can kind of opt out, and potentially then that nursing delegated task wouldn't be captured in the LSI. And the IQA will provide a nursing delegation withdrawal letter for the provider to fill out. And so that would, like I said, forego the delegation scoring there. And so we definitely know there's a lot of questions around nursing delegation. So we will hopefully get to address some of those here in our open Q&A. I do want to go ahead and provide a few resources. This slide deck is going to be sent out in our thanks for attending meeting, but it's also going to be posted on our webpage after the correction that needed to be done about 2 weeks from now. But we do have contact numbers and email addresses for Comagine when you have individual specific related questions. And then their website also is posted here, and their provider support page that is actually off of their original website. And then also our HCBS 1915I webpage that is continuing to be a work in progress. We're continuing to add features and interactive spaces for providers to get connected to resources and materials that are needed. So we definitely want you to use those. Just in general, a way to ensure kind of the right path for your question, here's some key components for starting that process. So if you have individual beneficiary related questions, so you have Bob and you have a question about his HCBS 1959 services, reaching out to Comagine Health at their support email is the best way to get started to that and get a kind of streamlined answer regarding that individual beneficiary. And then they'll loop in OHA as needed if it's something policy related. If it is truly policy, OAR, or federal regulation question related, then we do encourage you to reach out to our 1959 Medicaid policy email. That is managed by the policy analysts on the HCBS 1959 team, so myself and Natasha. And we will reach back out and provide support and technical assistance. Also, if it's just policy in general for home and community-based services, same email address. New mental health providers, if you are wanting to apply for a new application or getting process started to become a provider, we do have the licensing application email here. Great team of folks that will help you walk through the process in becoming a licensed mental health provider. And then existing license, so those that already have their license, if you have licensing questions or residential setting requirement questions, sending it to their actual TA email address for licensing is a better pathway for you. And then we also have our OEP or our eligibility email address here for general like OHP eligibility questions or individual beneficiary questions if you are needing to connect someone with, getting their OHP reopened or things like that. If you've got a letter from, renewing their OHP benefit, you'll want to reach out there. So that's a good little cheat sheet. And so we are going to open it up. I know we've had a very live chat and Q&A feature going on, and I know our team has been answering some as we go, but I do want to invite folks to raise their hand and use that raise hand feature to be called on, and we can ask you to come off mute and ask your question. We do want to be mindful just so that, many people can get an opportunity to talk, but to see if we can address as many questions as we can. And if for some reason we don't have the subject matter expert in the room that would need to answer that question, we will definitely be documenting it and taking it back. We've got note takers to be able to respond soon. Soon after the session. So I am going to open it up. I do see one hand up. Matthew.
I'd like to offer a clarification on the nursing thing. So where that's coming from in Jackson County is not necessarily for the delegated task of CBGs and catheters and such. It's more mirroring the APD model where a nurse can come in and work with the client, kind of like home health, but on a more ad hoc basis. It appears that what you're suggesting is not matching the APD model, and that was the question that originated here in Jackson County. So the answer, we know the answer, but that answer isn't parity with what we're seeking here in Jackson County for the nursing delegation or the nursing repayment. However, yesterday in our AFH meeting, we had a very lively discussion about the fact that mental health provider A writes the MHA and the treatment plan. However, the foster home is required to submit their care plan. We've heard a lot about the golden thread. However, what we're also hearing, both from Comagine, from a review that I attended as a CMHP, is that if the mental health provider does not, for example, include hygiene or ADLs because they don't feel like it's they can't validate it or it's out of their scope, but yet the home submits all the documentation, the golden threads from the home supports it on the daily log, on the weekly progress notes. But yet, if it's not codified in the MHA that the home has no basis of modifying because they didn't write it, it seems like Comagine is putting a lot of emphasis on documentation outside of the home, holding more weight while also including the fact that all that documentation from the home holds weight. The golden thread's not coming together for people here in Jackson County and likely statewide. Can we get some clarification on how the golden thread is supposed to be fairly implemented when our homes don't write the documents that are out of their control?
Thank you so much for that, Matthew. I am going to invite Ashley or Michael maybe to address that question or comment.
Yeah, I mean, I can begin it. In part, what you're pointing out here, Matthew, is a training issue. I think a lot of mental health providers feel queasy about identifying physical health limitations. And yet, that's really a part of that mental health assessment as it relates to services through that home.
Well, Michael, I'm sorry. This is incontinency, for example, and the person continues to have incontinency, but the therapist doesn't see the incontinency because it doesn't happen at the office. So the therapist is saying, I can't document it, but yet the home has all the documentation, and then Comagine's not acknowledging the golden thread of the home.
Yeah, I mean, just because a delusion doesn't happen at the office doesn't mean that the delusion doesn't exist as well, right? So part of I hear the problem, and you're just spelling it out in a very clear way, and I really appreciate that. It is a challenge for mental health clinicians to wrap their mind around medical impacts into mental health or even substance use.
Uh-oh.
Well, I saw somebody say that it was out of the scope of practitioners, but then it's not out of the scope to do the H&P, the health and physical, just noting it on they're not asking to diagnose it. They're just asking to include it as a health and physical notation on the MHA. And we've given those directions to those CMHP providers. But it's really, I think the problem is if the golden thread is being advocated, the golden thread is being punitive to the foster homes for a assessment that they aren't QMHPs and have no basis of modifying. And I think that's the big problem.
I think we had maybe a technical difficulty and Michael may have frozen. I just want to.
Well, I'm back. Somehow
There he is.
everything in the universe disappeared, and now it's back, and I am too. So I'm thankful for that. So I was just summarizing what the challenge is, and I don't have ready answers, but I do appreciate the clear highlight of the problem. I think part of what you can help do, Matthew and others, from the CMHP seat is to be facilitating these conversations and the need to include these elements in the mental health assessment. We're not asking clinicians, mental health clinicians, to become PCPs. We're just wanting them to review that as it relates to the behavioral health issues, which is fair. So thank you. Ashley, did you have more to add to any of that?
No, I think you covered it well, Michael. I think it really,
Okay.
excuse me, I think it does just reflect the need that like it needs to be a whole team process, right? Because we know the needs are complex and like you said, just because the delusion doesn't happen in the office does not mean it's not happening.
Yeah.
And really trying to use as much collateral information as possible is ideal when we're trying to do a comprehensive assessment.
Great. I do see one more hand up, and I apologize. Is it Rahel?
Yes. Hi.
Hello.
Hello. Hey, my question is, thank you for giving me the chance to speak. My question is, I just applied for the RTH, and I want to know if I apply for 3 rooms or for 5 rooms. Is there any difference? Or can we have more than 5? Is there any difference? How many clients we can have? I just want to know before I finish my application.
Yeah, I mean, that's a real licensing question. Do we have Connie here or someone from licensing to directly answer that? If we don't, I can pitch hit, but
Yeah, I think we may have them in the
we
subject
lose
matter
them.
expert chat, but maybe not in
Okay.
the room.
What I can
So we can put that
offer,
question in there.
yeah, what I can offer for guidance is that AFHs can, they often have licenses up to 5 beds. It's okay that they only utilize 3 of those, for instance, because of the facility. But the license is usually up to 5. You can't go over 5. I'm not sure why. I think part of that is there is a definition of AFHs in the licensing and maybe even in the contracts with OHA that you can't go over 5. Otherwise, you become more of a residential facility, and the home part of the AFH gets too diluted. So you'll want to work with hopefully you've been working with someone from licensing to help cultivate your program around, and they would be able to give you more guidance.
Hold on, if I may, I want to clarify. I think Rahel is used to working in the IDD system, would be my guess. This is not why my hand's raised, but this might help.
Yeah.
And the DD system, there are service payments changed based on what you are licensed for. And that is not the case, my understanding, with mental health, Rahel. So 5 is the max for RTH.
That's
It
right.
doesn't matter if you have 3 beds or 5.
That's right.
It's not better. Is it? Sorry, I missed it. Can you clear it one more time?
So
I think this is a conversation to have outside of here.
Okay,
I
no
agree.
worries. Okay,
I agree.
thank you.
Yeah, there is some stratifications and the such, but not for number of beds as it relates to AFHs and payment.
And we can definitely get you connected with the licensing team to give you some individual technical assistance there as you're going through that process.
Okay, thank you so much, guys.
You're welcome.
Thank you for your help, Anna. But that wasn't your question. So what would your question be?
Yeah, sorry about that. I was hoping to help, not
thank you.
over talk. I have 2 questions that hopefully are somewhat simple, but I know there's a lot of chatter or chat in the chat box. And it seems one thing that there's a common is, what is the quality assurance? Like, what QA is provided to Comagine when it comes to their assessments, if any? And then second, which is not related, is how is team defined? Because I was just doing a quick review and rule, and I don't see a clear definition of team. So because you have mentioned it a lot, and I think it's great, but also being really clear of like, who is the team?
Are you speaking to the care team specifically, like that
Yeah.
the individual has selected?
Yeah,
So,
like who is the team that should be providing input or yeah, who's the team that you
well,
reference?
it's definitely individualized. So the team should be inclusive of the individual themselves, their beneficiary, or legal guardian or representative. Likely, it should, um, with care coordination in general, it should include practitioners and other service providers that the individual is interacting with, CMHP, and other community partners that they are working with ideally, and should be reflective of who the individual wants there as well. There are some legal and authorized representative pieces that are required for Comagine Health to enable them to actually like conduct an assessment with, say, a nonverbal individual who needs to have their legal representative there. The documentation of that legal representative in order to conduct the assessment is pretty clear in rule, that they have to have that person documented in order to take kind of their word over an individual who may not be able to communicate. But I also want to invite Greg to come off and talk about what the care team might be inclusive of or is including. Greg?
Yes, thank you, Bunny. Generally speaking, this whole process is guided by the individual that has the need. And so it would really be anyone that they want there. However, it would be most helpful to have a rendering provider, CMHP, any care coordinators that are involved in the process. Um, those entities for sure, as well as obviously the beneficiary and their supports as well. So, want to mention as well that we are working on care coordinators to work with individuals, and so that would be ideal to have them attend these meetings as well, and those will be specific to HCBS settings. So um, that's yeah, generally anyone that is involved in the care would be ideal. And that may be even a PCP that is making an initial diagnosis, or if that's happening at the community mental health program. All of those individuals would be ideal to have in that setting. Also, I did want to mention to speak to the quality assurance piece, and Comagine Health does have a regular review process internal, and they have a inter-rater reliability process that is outlined with case reviews and feedback and things of that nature. And then additionally, OHA provides quality assurance reviews as well. And we audit case files and look at all sorts of things in terms of the assessment and then completeness of the file and things of that nature as well. So there is consistent feedback to the actual team members that are making those assessments and making sure that the full picture is captured when completing that assessment.
Did that speak to your questions, or did you have any follow-up from that?
No, that was great. Thank you. I'm going to let it kind of marinate a little bit. I'll let you know.
Great. Well, I know we have about 5 minutes left, and I know we wanted to answer as many questions live as we can, but we are very much wanting to capture questions. So if you have questions still kind of marinating in your brain, feel free to stick them in the chat, and we are going to capture that before we leave the room so that we can provide kind of a Q&A, session attendance of questions back out to y'all. And then just wanted to touch base and highlight some of the next upcoming engagement opportunities. So we do have office hours twice per month on the second and fourth Tuesdays of the month. And all partners and residential settings are welcome, the first office hour is usually focused and targeted towards community mental health programs, and then the secondary one is for residential providers. But again, all parties are welcome. We often really encourage folks to bring very granular or dedicated questions to staff in those sessions because they're a non-recorded session. And so we want to be able to offer some technical assistance there. And then in addition, we also have our next month's webinar topic is ready to go. We're going to be touching on state plan personal care and personal care attendant services and our new agency with choice program that's going to be launching here soon. Relatively soon. And just wanted to highlight that the reason we're bringing this topic to residential providers is because oftentimes you might be a setting where an individual is staying for a short period of time or a transitional period of time, and working to help those folks transition out of those settings into the community or in independent living settings. We want to just ensure that you guys have the resources and information and knowledge to support getting them set up with maybe state plan personal care or PCA services in their own home as they're leaving the residential settings. So just giving you some awareness of those options for individuals as they step down from 24-hour residential care into independent living care. I do see Matthew has his hand up, so I want to
quick preview for a future one, if you guys can. We talked about today that if Comagine doesn't authorize somebody, but Housing First and the embracing of Housing First still requires that they have a residency agreement, and then they would have to be given a 30 days notice. The provider could possibly not get paid their service payment. Is there a way that we can get some clarity on how Housing First being rolled out, how the lack of being authorized by Comagine for a second year, third year, whatever it might be, doesn't become punitive to the foster homes while not violate, I think there needs to, we're seeing in Jackson County this being a real concern. And, people are probably in foster care longer than they maybe should be. But then at the same time, if they ever lost it, they technically have a residency agreement from what OHA says. And I know that can't be answered in the few seconds here, but can we have that to be a robust discussion on how Housing First is being applied in the state of Oregon and how the concerns of providers and the CMHPs are being taken into consideration?
Yes, thank you for that. I don't know if we have someone to speak to that right now, but I want to tap Greg just in case, but I was thinking maybe there was some transitional support in the HCBS 1915I, but I wanted to tap Greg for that.
Sure. In certain circumstances, there is a transition rate. However, I'm not familiar with the Housing First rules, so don't want to speak too much there on that. But oftentimes there is an opportunity for that transition plan rate to get that individual in another setting that is appropriate.
And if you, Mike or Matthew, if you can write, if you haven't already, put that question in the chat, or at least kind of a summary of what you just spoke to, I think that would be super great for us to circle back with our Housing First folks and then be able to answer that in a better way.
Yeah, it's in the chat.
Great, thank you. I'm going to say the name wrong. Dehere?
Yes, Daraja.
Oh, thank you. Did you have a question?
Yes, I have just first I have. So my question is, a provider to get endorsement for job cutting the client. Sometimes your client get a job and they have hard time to find a job coach or job developer. So what are the steps to get or to become a job coach as well as a job developer for your client?
Okay. I'm wondering, maybe Michael, is that related to developmental disabilities?
Boy, job coaching probably best fits under supported employment. Supported employment is usually rooted at the CMHP and can be a part of ACT. Those are the two conduits that come to mind when you're describing this. I would work with your local CMHP to see what kind of supported employment services are available for your clients.
Okay. So right now I'm supporting him and he need attendee care. So I'm taking his medication, everything with him because until they get the job cut. So I ask her and my supervisor and she say like to get paid, you need to get endorsement license to your group home license to get paid an attendee care, job coach, or a job developer.
Well, those are two different things. As a provider, you can support the client in having mobile drug medication availability and the such, and that would be all under your license as a provider. You want to be very careful about having like an AFH kind of license and then trying to be a provider too, because AFHs are not service providers, they're habilitation providers. So that would be a good question to talk to your licensing liaison over at licensing and certification about.
Okay. Thank you so much, Michael.
You bet. You bet.
And I know we're a little bit over time, but I do see John. I just wanted to give you a second here to ask a question.
I appreciate that. Just two questions. So first one, I'm not sure if this is for you guys, has to do with like background checks for prospective providers. So like, I just submitted like a background check from like my previous workplace and they told me I needed to get like a, I guess, executive director background check, but with like BCU. And BCU said that they don't just hand out executive director background checks if you're not licensed. So I was just wondering if there was like a kind of a loop around that.
And can you tell me a little bit what license you're going for? Sorry.
For a residential treatment home.
Okay, perfect. Well, I think what we'll do is try to get you connected with our licensing team. I don't think we have a person in the room. They're on our subject matter expert chat, but if you can put your name and email, John, in the chat, then we can connect you with the folks that can be able to answer that question right away for you.
Yeah, no problem. Okay, just one last question real quick. Is there like a some kind of portal for providers to like make claims, bills, and like just look at service plans in Comagine? Is there like a portal, like a Comagine portal? How would providers be able to, make claims and billing and stuff?
I might invite Greg to talk about that real quick, if Greg's still with us.
Yes, I think I missed part of your question. Were you asking about a portal to upload assessment documents and things of that nature?
Yeah.
Okay. Yes, as of right now, there is not a portal set up. So the assessment information, like the CH006 packet, so the referral packet, can be securely emailed, or it can be faxed to the IQA. And that's our current process. And we're exploring a portal with provider access that would streamline that process. But we do not have a go live date as of right now, since we are still exploring that option and would need to conduct a pilot first.
So we're supposed to do the same thing, like for billing purposes. Also, like if we were needing to bill, we just do the same thing, like secure email.
Well, you submit billing claims into MMIS, and Comagine does not have any role in that, and so it's kind of a separate process.
Oh, okay. I wasn't familiar with MMIS. Is there like some kind of link that you guys can provide? Like
and there is a website that has some provider resources that we can connect you with as well, that talks about provider billing things and guides. And so when we connect you with that licensing team, they can help with that as well. So we'll get you connected with that.
Sweet. Appreciate it. Thank you so much.
All right. I do see one more hand. Tigeste?
Yeah, hi, it's Tigist.
So sorry. Thank you.
No worries. No, good morning. I don't know if I missed this question in the first few minutes of the meeting, but I put it in the chat. I'm new to this whole process, so I'm just trying to gather information. But where do we go about getting referrals for mental health clients? Is there a referral coordinator that we should be emailing or calling, or what does that process look like?
I am gonna maybe tap Michael and Greg. I do believe, alerting the licensing teams, but also your local CMHPs that you are licensed and ready to go. I know that
That's
there
right.
are lists that are sent out to local CMHPs and things when a license goes through. But Michael, do you want to speak more to that?
Yeah. So what kind of program are you running?
So I have a 24-hour residential group home right now.
Yeah, and you have a mental health license?
So, and that's the thing. I was talking to a consultant, and they were saying that if we're already licensed for a group home, we can admit a mental health resident.
So you're an AFH.
Yeah, so licensed with the state with Medicaid, but it's a 24-hour group home. So a little bit different than PD, but yeah.
So it sounds like a developmental disabilities home, right?
Yes. Yeah.
Yeah. Yeah. I think DD has a list of online programs where you can identify your specialization and things like that. As it relates to mental health, we do use DD homes, especially for clients who are having cognitive challenges beyond what we would be expecting from schizophrenia, which is a cognitive disorder, but there could be brain injuries and things like that that may not necessarily qualify people for other APD or DD services through that eligibility system, but we can still access it through mental health. And I think your consultant is in part speaking to that. And I would certainly just work with your local CMHP. That's going to be your best conduit and entity of collaboration for services that you have. But I would certainly reach out to the DD folks and just be sure that you have a listing of all of their programs, because us mental health folks tap into that list. And so you'll be able to show up there. There should really be no reason why any home, any facility shouldn't be packed full. We have clients for you.
And that's
yeah.
what I've been hearing, but I've kind of been getting the runaround when I've reached out to a few different folks. And I do have the background, I do have, the work experience as well as the master's degrees and behavioral health and all of those things. But I still have not been able to access the mental health clients. And so yeah, it's been kind of difficult because I hear from everybody that there's a lot of folks looking for placement, and I'm just not getting that. It's not translating over. I'm not seeing where that's at. So
yeah, I can fix that problem for you. I'll
that would be wonderful.
I'll send you some emails and some resources, but certainly, I mean, be working close with your CMHP. Sometimes CMHPs, want to collaborate very closely, and they can end up slowing down the process, even though they're being supportive of it, but they can end up from the provider perspective feeling like it's slowing down. But you really want to keep them as a really close collaborator, because they really do help a great deal. But as far as like referrals and stuff like that, I've written your name down. I'm very easy to find. If I don't email you in the next couple of hours, feel free to reach out to me. We can fix that
Did you
problem.
put your email in the chat, and then I will send you, all the things, my qualifications and
all the things. Yep.
Yes, please.
I can do that.
appreciate that.
Thank you all so much. I know we're over time, and I know we still have some questions unanswered. I'm so sorry. I know that I have to be respectful of our presenter time because I know they have to jump off to other meetings. So I will have to end our session today, but we really want to say how much we appreciate your time and your interest and your questions. And we will definitely be getting out to you a copy of the slide deck in our thank you email, but also hopefully have some additional written responses to your questions that we weren't able to address. Also, the slide deck will be posted and the recording will be posted in the next couple of weeks on our HCBS 1915i webpage, which is right here on this last slide. All of these links are interactive when you get your PDF document in the email. So we appreciate your time today, and thank you all to my presenters, and I will end the meeting today. Thank you so much.
Ani, do you have a moment to stay on just for clarification of something else?
I definitely can listen to it and then take it back if I need to get you a better answer.
It's more just a you and I conversation.
Oh, okay. Great. Well, do you want, Matthew, is it okay if I contact you outside of this just so it's not in the recording?
Sure, that works.
Okay, great. I will contact you here and try to get you set up with Teams real quick.
All right, sounds good.
Thank you. Bye-bye.